There is something quietly happening inside the bodies of millions of people over 60 right now, and most of them have no idea it's going on. It's not a new disease, it's not a sudden collapse, it's not something that shows up on a routine blood test and gets flagged immediately. It's something far more subtle, far more gradual, and far more common than almost anyone realizes. It's the medications they trust. The ones they take every morning without thinking, the ones their doctor prescribed years ago, the ones that became so automatic, so invisible, that they stopped being something to think about and started being just part of the day, like brushing your teeth, like having your coffee, like locking the door on the way out. But here's the thing, that almost nobody is told directly enough. After 60, your body is not the same body that was originally given those prescriptions, not even close. And I don't mean that in some vague way, I mean it in a very literal, biological, measurable way. Your organs process things differently. Your blood vessels respond differently. Your heart operates with different tolerances. And when version that were calibrated for a younger medication, or you keep entering a body that has fundamentally shifted in how it handles those chemicals, the result is not always protection. Sometimes it's the opposite. Sometimes the very medication that was supposed to guard your heart is the thing quietly putting it under strain. And the most unsettling part is that you won't feel it. There's no pain signal, there's no alarm bell, there's no moment where your body says something is wrong. It just happens slowly underneath the surface. And by the time it shows up as a real event, a hospitalized, a clot, a rhythm, disturbance, a bleed, the groundwork was laid for weeks, sometimes months, years before. And that's what we're here to talk about today. 8 specific medications that are widely used, commonly trusted, and rarely repetitive, but that after the age of 60, carry cardiovascular risks that most people are simply never made aware of. And I want to be very direct with you before we go any further. This is not about fear. This is not about throwing out your medicine cabinet. This is not about second-guessing every decision you or your doctor have ever made. This is about something much more practical. It's about understanding that your body has changed, and your medication routine may need to change with it. Because the most dangerous assumption in medicine is not taking the wrong pill, it's taking the right pill for the wrong version of yourself, and never revisiting whether it still fits now. On this channel, we take complicated medical information and make it something you can actually understand and actually use. If that matters to you, you can subscribe. But honestly, the most important thing you can do right now is stay with me through all 8 of these, because I can almost guarantee at least one of them, maybe more, is sitting in your cabinet right now, and what you learn in the next few minutes could be the thing that changes how you think about it, permanently. Now, before we go, medication by medication, you need to understand the foundation, because without knowing what's happening inside your body, after 60, the rest of this won't land the way it needs to. So let's start there. Your liver is the organ that breaks down almost every medication you swallow. It takes the chemical separate processes, it sends the active pieces where they need to go, and clears the waste. But after 60, your liver does not do this as quickly or as efficiently as it once did. It still works, but it's slower. And when it's slower, the drug lingers in your bloodstream longer than it was designed to. And that means the effect of that drug is stronger and lasts longer than what the original dose intended. At the same time, your kidneys, which are responsible for filtering your blood and flushing out what doesn't belong, are also losing capacity. They don't filter as sharply as they used to, so substances that should be removed within a certain window start hanging around longer, building up, accumulating, and creating effects that go beyond what was planned. Now add to that the changes in your cardiovascular system itself. Your arteries have stiffened over decades of use. The walls of your blood vessels are less elastic, more reactive, more prone to damage. The balance between clotting and bleeding has shifted. Your heart, which has been contracting and relaxing without a single break for over 60 years, is working with thinner margins than it had. At 40 or 50, it still functions, but it has less room for disruption, less capacity to absorb extra stress. And when a medication adds even a small amount of additional pressure to a system that is already operating closer to its limits, the consequences can be very different from what they would have been 20 years ago. And this is the core idea that most people miss. The pill didn't change, you changed, And medicine is not just about what you take, it's about the body that receives it. The same drug, the same dose, can be helpful in one context and harmful in another, and age, especially after 60, is one of the most significant contexts there is. And what makes this even more critical is that after 60, your baseline cardiovascular risk is already higher than it used to be. That's not a judgment, it's just biology. Decades of blood pressure, decades of cholesterol exposure, decades of wear on the vessel walls, the system is more vulnerable, more reactive, and less forgiving. And when certain medications are layered on top of that existing vulnerability, without being adjusted, without being reviewed, without being reconsidered, in light of where your body actually is right now, they can quietly amplify that risk in ways nobody sees until it's too late. So with that understanding in place, let's get into the 8 medications. And we're going to start with one that is so common, so familiar, and so easily available that most people don't even think of it as a real medication at all. The first one is non-steroidal anti-inflammatory drugs, commonly known as NSAIDs. This includes things like ibuprofen, naproxen, and various prescription-strength versions of these anti-inflammatory drugs. They are everywhere. They're in every pharmacy, every grocery store, every medicine cabinet in the country. And people use them constantly for joint pain, for back pain, for arthritis, for headaches, for general stiffness and soreness. They've been treated for decades as the simple, reliable answer to everyday pain, and for most people, for most of their lives, that's exactly what they were. But after 60, the way NSAIDs interact with your body changes in ways that most people are never warned about. Here's what actually happens when you swallow an NSAID. It blocks specific enzymes in your body that drive inflammation and pain, and that's why it works. That's why you feel better. But those same enzymes are also involved in maintaining the health of your blood vessel walls, in keeping your arteries flexible, in helping your kidneys manage fluid and sodium balance, and after 60, when your arteries are already stiffer and your kidneys are already operating at reduced capacity, NSAIDs begin to interfere with systems that are already under pressure, and the result is a gradual, often undetectable rise in blood pressure. Not a spike, not something you'd feel, but a slow, persistent elevation that builds over weeks and months. At the same time, NSAIDs cause your body to hold on to more sodium and water, and that extra fluid increases the volume of blood your heart has to pump every single minute. And now you've got 2 things happening at once: higher pressure in stiffer vessels and more fluid pushing through a heart that already has less reserve than it used to. Large studies have confirmed this. People over 60 who use NSAIDs regularly have a meaningfully elevated risk of heart attack and stroke compared to those who don't, and yet millions of people continue taking them daily, sometimes for years, because the pain relief is immediate and obvious, and the cardiovascular damage is completely invisible. You feel the pain go away. You don't feel your blood pressure rising. You don't feel the extra fluid building around your heart. You just feel better. And that illusion of safety is what makes this so dangerous. This does not mean NSAIDs should never touch your lips again. It means they need to be used deliberately, with awareness and with regular reassessment. Short-term use for a specific flare may still be perfectly fine, but ongoing daily use after 60, without anyone reviewing whether that's still the wisest choice. That's where the invisible accumulation begins. The second medication is one that people often start for a short-term reason and then quietly never stop taking. It's called a proton pump inhibitor, or PPI, and it includes medications like omeprazole, esomeprazole, lansoprazole, and others in the same category. They are prescribed for acid reflux, heartburn, stomach ulcers, and to protect the stomach lining, especially for people taking other medications that irritate the digestive system, and they are remarkably effective at what they do. They reduce stomach acid, they stop the burning, they heal the irritation, and because they work so well, people stay on them often for years, sometimes for decades, without anyone ever circling back to ask whether they still need them. But here's what is almost never explained to patients. Stomach acid is not just a source of discomfort. It serves essential biological functions. One of the most important is helping your body absorb critical nutrients, specifically magnesium calcium, and vitamin B12. And when stomach acid is suppressed chronically, over long periods, these nutrient levels begin to decline, slowly, steadily, and silently. Now here's where the heart comes in. Magnesium is directly involved in maintaining a stable heart rhythm. When magnesium drops below a certain level, the electrical system of your heart becomes less stable, and the risk of irregular heartbeats increases. Some of those rhythm disturbances are minor, and some are dangerous. Calcium affects how your blood vessels contract and relax, and vitamin B12 is involved in the structural integrity of blood vessel walls and in proper nervous system function. When all three of these are gradually being depleted, the cardiovascular system becomes more fragile, more reactive, and less able to handle stress. But there's another layer to this that is still being studied, but increasingly supported by evidence. Long-term PPI use appears to affect the endothelium, which is the thin inner lining of your blood vessels. This lining controls blood flow, clotting, and the ability of your vessels to expand and contract appropriately. When it's impaired, the risk of abnormal clot formation goes up, and with it, the risk of serious cardiovascular events. And none of this produces symptoms you can point to. It just accumulates underneath the surface while you go on taking the pill, because it was prescribed once and never revisited. The path forward is not necessarily stopping immediately. It might be reducing the dose. It might be switching to a different class of medication. It might be simply having a conversation about whether the original reason for starting the PPI even still exists. But that conversation can only happen if you know to bring it up. The third medication is one that many people over 60 have been taking for years, often originally prescribed during a difficult period of anxiety or insomnia, and then continued long past the original need. These are called benzodiazepines, and they include drugs like diazepam, lorazepam, alprazolam, and similar medications in the same class. They work by calming the central nervous system, reducing overactivity, slowing down the brain's response to stress, and they are effective at doing exactly that. The problem is, what else they slow down. As you age, your body becomes more sensitive to these drugs. The liver processes them more. Slowly, the drug stays active in your system longer, and the sedating effects become stronger, even if the dose hasn't changed. And this creates a cascade of effects that directly impact your heart and circulation. First, there is the reduction in physical activity, because when someone is more sedated, more fatigued, more slowed down, they move less. And movement is not optional for cardiovascular health. It's fundamental. Your circulation depends on it. Your blood flow depends on it. Your body's ability to prevent clots depends on it. When movement decreases, blood flow becomes sluggish, and the risk of dangerous clot formation rises. Second, benzodiazepines can suppress respiratory function, particularly during sleep. They can worsen or contribute to conditions like sleep apnea, where breathing repeatedly stops and starts throughout the night. And each time breathing pauses, oxygen levels drop, and every one of those drops puts direct strain on the heart, forces blood pressure up, and over time contributes to cardiovascular damage that accumulates night after night after night. And from the outside, this doesn't look dangerous. It looks like someone who is just tired, who wakes up groggy, who moves a little slower than they used to. But underneath, the cardiovascular system is being stressed repeatedly and not given the chance to fully recover. This is not about saying benzodiazepines are evil or that nobody should take them. It's about recognizing that a dose or a frequency that made sense 5 or 10 years ago may now be producing effects that are disproportionate to the benefit. And that kind of recognition only comes through honest reassessment. The fourth medication is one that people don't even think of as a cardiovascular concern because they associate it with something completely different. It's decongestants, especially those containing pseudoephedrine or phenylephrine. These are found in dozens of over-the-counter cold and sinus products, the kind you grab off the shelf when your nose is stuffed up and you just want to breathe again. They work by constricting blood vessels in the nasal passages, which reduces swelling and opens up the airways. And they do work, but here's the critical piece. That constriction is not limited to your nose. It is a systemic effect, meaning it affects blood vessels throughout your body. When blood vessels constrict across the body, blood pressure rises, the heart has to pump harder against more resistance, and the cardiovascular system is placed under increased strain in a younger body, with flexible arteries and plenty of cardiac reserve. This is usually tolerated without much issue, but after 60, when the arteries are already stiff, when blood pressure may already be elevated, when the heart is already working closer to its limit, that added constriction can push things past a threshold. And what makes this even more concerning is that decongestants almost never taken in isolation. They're taken on top of other medications, blood pressure drugs, pain relievers, sleep aids, and each of those medications is already exerting its own influence on the cardiovascular system. And when you add a decongestant, even for a few days, you create a situation where multiple forces are simultaneously increasing the load on your heart and vessels, and the combined effect can be far greater than any single alone one. And because it's just a cold medication, because it's over the counter, because you've taken it before, nobody thinks twice about it. But in an aging body, with a full medication list, that casual decision carries a very different weight. The fifth medication is one that might surprise you, because it's been positioned for years as one of the safest medications you can take. It's a class of drugs called corticosteroids, and I'm not talking about the child athletes misuse. I'm talking about medications like prednisone, prednisolone, dexamethasone, and similar anti-inflammatory steroids that are prescribed for conditions such as asthma, chronic obstructive pulmonary disease, rheumatoid arthritis, lupus, inflammatory bowel disease, and dozens of other conditions where the immune system is overactive. And inflammation is causing damage, and they are powerful. They reduce inflammation rapidly and effectively, and in many cases, they are genuinely necessary. But after 60, especially when used frequently or over extended periods, corticosteroids begin to affect the cardiovascular system in very specific ways. First, they cause the body to retain sodium and water, which increases blood volume and increases blood pressure. The same mechanism we discussed with NSAIDs, but often more expressed. Second, they affect how your body processes sugar, and sugar can elevate blood glucose levels, even in people who have never been diabetic. And elevated blood sugar over time damages blood vessel walls, accelerates plaque buildup, and increases the risk of both heart attack and stroke. Third, corticosteroids can shift the distribution of fat in your body, promoting accumulation around the midsection and around the organs, and visceral fat, the fat that wraps around your internal organs, is one of the most significant independent risk factors for cardiovascular disease. And fourth, they can weaken the structural integrity of blood vessel walls themselves, making them more prone to damage and rupture. And all of this happens in the background while the medication is doing its intended job of controlling inflammation, so the person feels better, the swelling goes down, the pain decreases, the flare subsides, but underneath the cardiovascular system is absorbing these secondary effects, day after day. And for people who cycle on and off steroids repeatedly, or who remain on low doses for extended periods, these effects are not theoretical, they're well documented, and they are significant. The sixth medication is one that people over 60 are prescribed more than almost any other age group, and it's one that very few people question because it seems like such a standard, straightforward treatment. It's a category of medications called antidepressants, specifically certain types within this class. And I want to be careful here, because depression is real, it's serious, it's undertreated in older adults, and medication can be life-changing. But what needs to be understood is that not all antidepressants interact with the cardiovascular system, the same way certain older classes of antidepressants, called tricyclic antidepressants, which include drugs like amitriptyline, nortriptyline, and imipramine, have direct effects on the electrical conduction system of the heart. They can alter the QT interval, which is a measurement of how long it takes the heart's electrical system to reset between beats. And when the QT interval is prolonged, the heart becomes vulnerable to a specific type of dangerous arrhythmia, an irregular rhythm that can in some cases become life-threatening. And after 60, when the heart's electrical system is already less resilient, when other medications may